Welcome everyone to Friday afternoon teaching. I'm delighted to introduce Dr. Jav Dadawal, who is one of our interventional radiologists, who's going to tell us about mechanical thrombectomy in pulmonary embolism. So over to you, Jav.
Thank you, Kaz. Good afternoon, everyone. And thank you to Matt as well for this opportunity to speak to all you today. Yes, so we're going to talk about percutaneous thrombectomy in the context of pulmonary embolism. It's a relatively new development, and we have Karen from Inari. Inari is the company who makes the device that we now stock in Glenfield, and she's going to, with the guys here at the end of the presentation, go through the device that we're using for PEs now. Okay. So just a quick bit of background, which you'll know better than me as a radiologist. Yeah, PE is a very, very common cause of morbidity and mortality. And the etiology, as you can see here, is sort of multifaceted from ultimately the initial pulmonary artery occlusion. It slowly develops into pulmonary vascular resistance. That increases your RV afterload, which ultimately results in decreased RV output, reduced LV preload, and ultimately you get shock and death. So the European and American guidelines sort of stratify PE into different subcategories. The massive or high risk PEs are those in whom there's hemodynamic instability, as well as sort of the increased PESI scores as well, 3 to 5. On CT, or on echo, you'll have evidence of right ventricular strain as well as evidence of myocardial necrosis. There's a subset of patients within the intermediate group, as per the European guidelines, and whom we're quite interested in, because they're not really unstable as such from a hemodynamic standpoint, but they do have both evidence of myocardial necrosis as evidenced by BNP measurements or troponins, or RV strain on echo or CTPA. And these are the types of patients, as well as the massive PE patients, in whom we're interested to possibly offer PE thrombectomy, which I'll come on to later. Just very briefly, this is your classic sort of saddle embolus appearance. In this type of scenario, you very, very commonly get a flipped RV-LV ratio. So the RV in this situation is larger in diameter compared to the LV, which is a good surrogate for right ventricular dysfunction and necrosis. And this is just sort of echocardiographic correlation of the CT image. Commonly, if you're looking at the CTPA yourself, you can see contrast reflux into the juxtahepatic IVC, which also is another surrogate for right ventricular or impairment or dysfunction. So in the absence of any contraindications, all QPE patients will receive or can receive appropriate anticoagulation therapy. The European and American guidelines both recommend systemic thrombolysis in massive PE patients because of the high mortality rates associated with massive PE. In patients with submassive PE or intermediate risk PE, both the societies, Europe and America, the guidelines are less clear in terms of how to escalate management should standard anticoagulation not work. Whether systemic thrombolysis should be administered, or what's being investigated now is whether PE thrombectomy with these new devices is more appropriate. So with regards to catheter-directed therapy, we tend to offer this as opposed to systemic thrombolysis in a certain subset of patients. So classically, it was those in whom there was contraindications for systemic thrombolysis, and it's a large list, but things like recent stroke or trauma, as well as recent major surgery, amongst many others, are contraindications for systemic thrombolysis. Catheter-directed therapy in years gone by used to be a case of puncturing the femoral vein and getting a pigtail infusion catheter into the pulmonary trunk and just starting a thrombolysis infusion over a couple of days. But that involved one ITU or HDU admission, several visits, interventional radiology. And so we only did very, very, very little numbers of those types of patients because of the massive logistics involved. And to be frank, the outcomes for these types of patients were also very questionable as well. It was a matter of just doing the infusion, repeating the angiogram and seeing if the clot cleared, or even just using the pigtail and just sort of twirling it around and trying to break up the clot, which works sometimes, but usually doesn't. Ultimately, the endovascular Holy Grail is a device that can be used by one operator in one procedure with minimal bleeding, resolution of clot, and very little blood loss. And so this is what we're hoping these devices that we now started to use are going to help us do, because the patients can come to IR once, they recover quite quickly with regards to their hemodynamic parameters. There's no lytics involved, and if they need to admission to ITU, it's usually for a very, very brief period of time, for a day or so. So with regards specifically to submassive PE or intermediate risk PE, it's a bit unclear with what role catheter-directed therapy is playing. It's still under investigation. A lot of trials have happened and are going on at the moment. This is just a slide just talking about different parts, different aspects of these trials. I think all the trials, while the evidence has not been great up till this point in time, these trials do demonstrate reduction in pulmonary artery pressures and improvement in the RV-LV ratio after catheter-directed therapy, but there's a lot of key limitations. A lot of recent studies up to this point using these new devices, they're relatively small, with limited endpoints, lack of control arm, and the long-term data was left a little bit wanting. So as a result, in the most recent European and American guidelines, catheter-directed therapy in the context of intermediate risk PE, so those are the PEs that they're not unstable, but they do have right ventricular strain or necrosis, consider CDT as an alternative to systemic thrombolysis in patients who are not candidates for systemic thrombolysis. And the Americans say consider CDT in those types of patients who, despite adequate anticoagulation, and maybe they actually did receive systemic thrombolysis, may continue to deteriorate if they became subsequently hemodynamically unstable. So this is a quite busy slide, but what it really entails is all the different trials up to this point. And as you can see, the numbers are quite small, but it's just looking at sort of the three different devices as well as standard fibrinolytic therapy for PE, and the FlowTriever system is the one we have here at Glenfield. And I think the thing I just wanted to get across from this slide is that it's a very safe device with a major bleeding rate of 1% within 48 hours, and the device time of usage as compared to some other devices is very short at about 1 hour. So that compares to a thrombolytic infusion, which used to be the case, and that used to be 48 to 72 hours and required several visits to the IR department. So Inari, the company whose device we now have, they're doing a trial which has actually just started recruitment, multi-center RCT, 1,200 patients. And what they're going to look at is intermediate PE, so those patients I was talking about before, them having this device, PE thrombectomy versus standard anticoagulation, to see long-term who does better really. And then they're going to look at a composite of clinical outcomes, including things like mortality, hospital readmission, dyspnea measurements. And so they want to just go beyond this classical RV-LV ratio measurement. So a lot of the trials previously were looking at things on imaging to see whether or not there'd been a response to the use of these devices. But I think going forward, we need more robust evidence. And so this trial is going to help us produce more robust guidelines, and so we can deploy this device in the right subset of patients. I think one thing we want to emphasize is that this device is not for all PE patients. There's only a certain subset of patients who are going to benefit from this device. But as the years go on, over the next couple of years, we're going to get that more robust data so we can use it a bit more effectively. I think what ultimately this new trial, Peerless 2, is going to address is that with these new built tools for PE thrombectomy, we need to be thinking a bit more critically about whether a conservative approach to intermediate risk PE should remain the standard of care, and that's something we're going to be looking at. NICE actually this week published some new guidance with regards to percutaneous thrombectomy for intermediate risk or high risk pulmonary embolism. So what they're saying is for high risk patients, so the patients that you guys probably come across more often, in whom there's hemodynamic instability and they're not candidates for systemic thrombolysis, then you can do percutaneous thrombectomy, but you just need to have the appropriate clinical governance in place with regards to auditing your outcomes and that data as well. I think they're a bit more conservative with regards to intermediate risk PE, and I think that's understandable given the relatively poor evidence base up till this point in time, or less robust evidence base up until this time. And they recommend that if you want to use the device in intermediate risk patients, it should be really only in the context of research, and as well as having those robust clinical governance frameworks in place as well. And that's just really hot off the press this week. Doesn't really change in terms of what we do. So we've done 5 patients now since the end of September in Glenfield, and a lot of them actually are more towards the high risk category. But we'll get onto that in the subsequent slides. So this is not really a formalized pathway. This is just something I really came up with, but I think I envisage over the next 6 months, after discussion with stakeholders such as yourselves, ITU, respiratory medicine, thoracic surgery, A&E, we need to sort of come together to formalize a pathway for these patients, because I don't think it's really ideal to have only certain interventional radiologists doing the procedure, and it really you're only getting lucky depending who's on call. And then also people are finding out that we can offer this procedure, but they may not have been aware before. So I think over the next 6 months or so, we're going to sit down and really formalize a pathway. But I think it'll probably be based on something sort of like this. So when the PE is diagnosed, if you're high risk massive PE, you can consider systemic thrombolysis. If they continue to deteriorate, then we're happy to take a referral for PE thrombectomy. If, for example, they have absolute or relative contraindications to thrombolysis in the context of massive PE, then we'd be happy to be contacted to offer mechanical thrombectomy. The ideal candidate for PE thrombectomy are those who have failed thrombolysis, who have contraindications to thrombolysis, and those also, they have to have an amenable clot burden on CTPA. And that's something that we'll judge if every time we get a referral as well. So this is the intermediate group. So is there signs of RV dysfunction? Then yeah, they're automatically an intermediate risk PE. Are there signs of RV dysfunction on imaging and raised troponin, or signs of RV dysfunction or biochemical evidence of RV dysfunction? So things like raised troponin and BMP, then they start the sort of heparin. And if they continue to deteriorate, then we'd be happy to have that discussion about mechanical thrombectomy. But at the same time, they could also, if it's early enough, consider systemic thrombolysis. But I think at every point in the pathway, we'd be happy to be contacted early on if there's a question about whether a patient may or may not be a candidate for mechanical thrombectomy. And that's something that we can have, if they're not, then I still think it's a worthwhile conversation to have. This is a very busy slide. We won't go through all it. This is just a slide I took from the Royal London Hospital. So this is their pathway. But honestly, I think what I really want to get across from this sort of pathway, and I know you can't read this all, is that a lot of the London centres have PE response teams. And so there's a lot of people on these PE response teams, radiologists, A&E, ITU, respiratory medicine, thoracic surgeons, cardiologists. They all sort of come together, all representatives from all these bodies. If there's an intermediate high risk PE as well as massive PE patients, and they'll all come together quite quickly and decide what's the most appropriate course of action. And not every time are they going to make a recommendation for mechanical thrombectomy, but I think it just has all the right minds in the room. And I think with things like Microsoft Teams, I think it's a lot easier now to get all these different people together to make a decision with regards to, okay, well, should mechanical thrombectomy be offered? And I think the CTPA being available, ECHO, and then you have all these other clinicians involved, I think everyone can arrive at the right decision for the patient. So that's, I think in a couple of years, if there's an appetite for it locally, that's something that could be considered as well. So I'll just go quickly through the 5 patients who we've done since September. This is our first patient. So this was a transfer from Lincolnshire. This is a patient with empyema and bilateral PE. The referral came from thoracic. So they were referred to thoracic surgery. Would you consider surgical thrombectomy? And they contacted us because it was more. It wasn't a saddle embolus. As you can see here, there's a filling defect in the right segmental pulmonary artery, as well as there's a big organized clot here in the left pulmonary artery. This person has several week history of symptoms, and the device that we have here today can be used up to 6 weeks from the onset of symptoms. So we thought, okay, well, I think we can offer PE thrombectomy here. So we puncture the right femoral vein. It's a 24 French system that we like to use. We get into the right heart, get a pigtail, we do a run. So you can see the PE there. You can see is a very, and look, there's nothing really getting into the left lower lobe as well. So we sucked out some clot, and as you can see here, it's not really fresh clot. It's very white and it was very rubbery in appearance. So very organized chronic clot, and we find that even with patients with acute symptoms, we're getting quite a lot of chronic stuff out. So which is very interesting. And as you can see here, the right is clear. The left, we tried, and the left is always harder to actually do percutaneous thrombectomy just because of the angles involved. But this was way too organized. It was like it was like a golf ball. We just couldn't suck it out. We kept engaging it with our catheter, and despite we tried. However, the patient, went from MRC dyspnea 4 to 2 and was discharged and is now ambulant and being followed up as an outpatient. So that was quite good. That was our first case that we did here at Glenfield. This is our second case. This is the one you were involved with, Kaz. Actually, 29 weeks pregnant, massive PE and echocardiographic evidence of right heart strain. You can see the filling defects on CT on the coronal projection here on the right, and then you can see it here on the left. And then this is the pre-procedure CT. You have to kind of get your eye in for it. So you can see in the left side here, look how the contrast is filling the rest of the lung at the top and in the middle. And then look, there's a sort of a low density area in the left lower zone, and on the right it just sort of looks quite pruned, and then there's a bit of clot here and maybe some here as well, a bit there as well. So we sucked at my colleague Hamza and Dr. Adair, they did this procedure, and the blood flow to the lungs is now much improved. That's what came out. That's proper fresh acute clot, which we managed to suck out. And so the procedure, obviously when we start, the procedure takes a couple of hours, but I think we've been progressively getting quicker to the point that we should really be doing these procedures in an hour or so, because having a 24 French sheath or catheter through the right heart in someone who has right heart impairment, not ideal for an extended period of time. And what we found in some cases is that if they did deteriorate with our catheter in, we'd have to pull it back, put it forward, and it just sort of required a lot of manipulation or downsizing to a 20 French or 16 French system. And so her mean pulmonary artery pressure went from 30 to 25. She now has normal RV function on her most recent echo, and she's ambulant and she's delivered her baby normally, and she's completely symptom free. That was some more clot. Sorry, there's a lot of clot pictures. This is the stuff that we try to post on Twitter and stuff. Everyone gets excited. Yeah, so she's completely symptom-free, which is good. But again, I think as Kaz might allude to later, this required a lot of coordination because she presented to the Royal initially, and obviously obstetrics is based at the Royal, but our device and cardiorespiratory center of excellence is here at Glenfield. So I think we just need to decide where we will offer this procedure, I think, just at Glenfield. And I think if people need to be transferred, then I think we'll do that transfer in conjunction with yourselves and things. But I think ultimately this was a good outcome. So this was the case I was involved with. There's a 46-year-old from Derby with bilateral PE, intubated, incidentally presented with a cerebellar stroke before it became breathless, and was found to have a PFO. And in fact, when I did this case, my wire went through the PFO into the
brain.
No, not that far, but into the aortic arch, and it quickly became apparent it was quite a large PFO, and that's probably why she had her stroke. And on this angiogram, you can see there's a large volume of clot here. There's also some clot here, and look, there's not much filling in the left lower lobe. So there's clot. You can see there's like a big wedge of clot here as well. So we managed to suck out the right side. That's nice and clear now. That's all filling. The left side, we sucked out some from the left upper lobe, but I left this behind just because the patient was doing fine by that point and had improved actually on the table. You can tell, even though they were intubated, and they're on a little bit of inotropic support, their requirements tend to decrease quite quickly, even on the table. So we had a good result here. The MAP went from 37 to 32. She's now extubated and well, and being managed for her PFO. So this is a 31-year-old, morbidly obese, bilateral PE. She was thrombolized to little effect. Some clot here, bit of clot down here. That's just to give you a perspective of how big the catheter we're using. So that's a 24-French catheter. Essentially, it works by suction. So you engage the clot with the catheter. You then will pull back on a syringe, as we'll demonstrate later on, and then you just open a stopcock, and it just pretty much solves 80 to 90% of the time. That's all you need to do. If we need to do more, there's discs that we can put in. So you put the catheter right in, put the discs in, you expose the discs, and you can just troll the discs back, and that'll just scrape off whatever's left. And that's the left side as well. And then this is what we managed to get out. A bit more clot. They're doing well. So their MAP went from 37 to 27. They were quite quickly stepped down to the ward, and are doing okay. So this is the last patient, fifth patient, which was done a few weeks ago. 57-year-old metastatic cancer, large volume PE. They didn't want to thrombolize the patient because of the metastatic cancer. Right heart impairment. I think this bit of clot here. No filling in the left lower lobe. We find that the lower lobes are the ones that we go after with primarily just because they're easier to get at. And then usually after you clear the lower lobe, you don't have to get a perfect result. If there's a bit in the upper lobes, but you've taken a large volume of clot in the lower lobes out, usually that's enough. And usually if you've cleared one lung quite well, that's usually enough as well. So you're not looking for perfection here because you don't want to be there all day, trying to get every bit of clot out. It's just to get enough just so the right heart impairment improves. And then that's what we managed to get out. So their MAP went from 28 to 22, which is quite good. And yeah, I have a few more slides, if that's okay. Just my next bit of the presentation. Those are just myself and Dr. Algendi's emails. Those were the two that's sort of leading on this. Just moving on. This is just some company slides because we have Karen here from Inari. So I'm just going to fly through these very quickly, just to talk a bit more about the device specifically. So venous thromboembolism is a high burden of disease, as we know, and as I've alluded to, third leading highest cause of cardiovascular death. And obviously, if we look at the 30-day all-cause mortality, it's almost 30% for high-risk PE. And that, so with regards to this device, actually the 30-day mortality rate is 1%. So it's quite a big difference there as well. Do we need an interventional treatment for acute PE? I think, as the data has suggested with regards to mortality, I think there is a role for these devices in acute PE. More clot. So conservative therapies, yeah. So PE treated with conservative anticoagulation, obviously you do get chronic PE syndrome in a big significant portion of these patients. And as we have found, the majority of the venous clot is actually lytic resistant. And what we found in all 5 of these cases, that all the clot that we managed to take out, it's not just, as I've alluded to before, it's fresh red clot like this over here. You get a lot of this rubbery, fibrous clot out. And so the patient may have had symptoms for ages, and then it's an acute or chronic deterioration they've experienced. And so it's a lot of this collagen type clot, which we're managing to extract as well. Obviously, if you do leave a lot of clot behind, there's an increased risk of death, increased risk of heart failure, as well as increased risk of CTEP or chronic pulmonary chronic VTE, leading to right heart impairment. we'll just skip some of these. Sorry, that's about DVT. I think ultimately there's an unmet need in PE in which this device can play a role. I think we look at that high mortality and high risk PE, and actually the risk of mortality in intermediate PE is also 15%. There is a portion of patients in whom systemic thrombolysis is not ideal, such as if you're pregnant or having active malignancy, in whom we can offer this device. Retriever system quickly. So obviously, as I alluded to, 16, 20, 24 French. That's the device itself. That's the suction the suction syringe. It's basically, it goes through a sheath, and then that's the whole device. So it's quite simple actually to use. And then these are the discs I've explained that don't tend to be required, but are available should we need, should there be some residual clot we want to show. So ultimately, we want simple devices to remove large volumes of clot. There's no capital equipment, no lytics. Hopefully it avoids an ICU state, and there's rapid symptom relief. Just skip these. We have a lot of so the company has a lot of registries now with regards to enrolling a lot of these PE patients, so we can get more real world data to improve overall outcomes in PE, in the context of PE. The results show, with regards to the registries, quite significant hemodynamic improvement, whether it be with regards to pulmonary artery pressure, cardiac index, and things like heart rate as well. Minimal hospital hospital resource utilization because of the FlowTriever. Obviously, is much less. The all-cause 30-day readmission rate is quite low with the use of the device. And in 2/3 of patients, there was no overnight ICU need. So just skip to these ones. So this is the slide I wanted to show. So I think MIs were treated with systemic thrombolysis, a couple of decades ago, and then they progressed to primary PCI. I think more recently you have stroke with regards to mechanical thrombectomy, and the evidence being robust. I think the third arm of this will be with regards to DVT and PE, where I think there's going to be a subset of patients in whom anticoagulation alone is not going to be sufficient, and I think we just need to develop a bit more robust evidence to develop guidelines and find out who specifically we should be offering the mechanical thrombectomy to. But I think up to this point, just to summarize, it's those patients, high risk and intermediate risk, not candidates for systemic thrombolysis and who continue to deteriorate despite systemic thrombolysis, who would be happy to be contacted about. Thank you.
Brilliant. Thank you very much, Dan. Do you want to stop sharing, and we'll see if the guys at the Royal have got any questions, and then we can have a look at it.
So just from the Royal, my name's Gareth Williams. I was involved with Kaz in the pregnant lady.
Yes.
Just to be clear, and I think I know the answer, but prior thrombolysis isn't a contraindication to mechanical thrombectomy. There's no issues with having thrombolized the patient prior to the procedure.
No. So if they've been thrombolized or if they're on a heparin infusion, we're happy to. We wouldn't delay the procedure or necessarily say it's a contraindication. It is a large venous puncture we're doing, but up until this point, we've not had any groin complications. We tend to just take the big sheath out and do a purse string stitch, and usually that's sufficient. And actually, if they're on a heparin infusion, depending on the operator, we've been just saying, oh well, just continue it. It'll be okay. Because we're quite confident that for venous punctures, it's usually no problem.
As in, you wouldn't, no time at all. You wouldn't, if it, no, sorry, Gareth, so just checking post thrombolysis, you wouldn't say an hour post or no. 2 hours post.
Well, because I think if they're thrombolized in the morning, for example, and coming to Glenfield, usually the delay is about an hour.
Okay.
Yeah. So I think if they've been thrombolized and we're going to do a venous puncture, I personally, and I think I know Dr. El-Gendi, my other colleague, would be happy to puncture a femoral vein. And also, if they're on a heparin infusion, if it's not being stopped, we wouldn't say, oh, well, it's not being stopped. We don't want to start the procedure just now. We would probably just say, oh, well, just continue it and we'll see how we go. I think if they were a very, very large patient and we thought access was going to be very, very difficult, I think maybe we would have a think about that. But there's no contraindication from our point of view if they've been thrombolized and if they need an urgent procedure, if they're deteriorating despite thrombolysis. I think on the risk-benefit ratio, you'd probably just say, okay, well, we'll just do the procedure anyway.
Okay, thank you.
Are there any more questions either from your end, Gareth, or from people listening at home? Speak now, forever hold your peace. Go on then. What's your question?
Were most people aware of? I know you were, Kaz, a few months ago with the pregnant lady case. That did have the device, or that were you aware of the device from before I came today?
Oh, to be fair, we after that pregnant lady, we basically messaged everyone who worked in ICU. So after that, we knew.
Oh,
it wasn't until that day that I think, because it was news to me and Gareth.
I see. Yeah, we're. For the time being, we're offering the procedure or the device on an ad hoc basis, and obviously long-term going forward, that's not ideal. But I think we need to sit down with the relevant intensivists as well as the other specialties to come up with a pathway to see who wants to be involved with regards to these patients. Because as a radiologist, it's easy for me to say, oh, well, I have the device and I'm happy to be contacted whenever, that's fine. But there's a lot that goes around with regards to the patient, how they should be managed.
Mm-hmm.
But I'm hoping with regards to with use of the device, the intensive care may be needed briefly, but hopefully not for that long, maybe for a day or two. But yeah. Yes, sorry, go ahead.
Thank you very much for that, actually. I think it's quite timely. So I might have missed it.
Yes.
So when you access the pulmonary artery, do you access it from the groin or from the neck?
You can do both, but the traditional way is to go from the groin. Just because it's a bit more of a, once you get into the pulmonary trunk, it's everything straightens out and it's quite easy.
Right.
But
I've already asked about getting past ECMO.
Yeah. But there's
I'm gonna
obviously
get
there is a population of these guys who go, once you plug out the clot, they go into a systemic reaction. So the second phase of PE for us that we find, especially in thrombolyzed deep massive PE,
yes,
is that they go into almost a distributive shock like a sepsis, because the lung has been ischemic for a long time, and all that ischemic metabolism washes into the system. And the RV still struggles, not because it's obstructive now, but because it's not getting good perfusion. So so it's called the second phase of RV failure, where patients have the radial obstruction but can still die. So we tend to support them through that. Now, one way of salvaging that is putting them on ECMO.
Yes.
And we have the capacity to cannulate, to do what we call an RVAD configuration, where we put a cannula into the pulmonary artery. I was just wondering, looking at your device, because if you accessed it through the neck, because we have two types of devices. Yes. There's one that is a single cannula that we can put in, and there's one that is a double lumen cannula, where just one cannula that goes into the pulmonary artery and just suck proximally and goes distally. That if you've got a guide wire in the pulmonary artery, or you've got a device that just variable that but yeah, I mean, it's probably something that if it came to it, because we did have one case. I don't know if it was discussed with you. We're all ready to do it. There was a patient on ECMO who had massive PE, and her RV was struggling. She was ECMO for a while, and we had a conversation with one of you, and we were going to get the reps in to do thrombectomy. But we now had conversations with the transplant center, and who all felt, we should just wait. And we waited, and she did well. She came, but it took a while. But the conversation then was that she may go up, because obviously once that lung has been ischemic for a while, not just days and weeks, and she's so sick that once you take that out, she'll be seriously, and that RV needs support. So we were prepared to offer that support. So it'll be one of those conversations where we'll have, I don't know if it's more technically difficult for you to go through the neck, or it's easier if you were, obviously you want to do what's easy for you. So, I mean, it's one of those conversations to have. So we have a VPA camera, like a single cycle, that's easy to put through the neck. But also, all we can do is put we also have single stage, so 1921 French cannulas that we can put in, but I'm not just sure it will get all the way from the groin.
Yeah.
I don't think it's long enough.
Yeah.
Yeah. So that's just the key issue. So a lot of those kind of conversations that we probably have in those kind of that
Exactly.
context.
Yeah. No, I think it's a more collaborative thing in terms of access. Traditionally, for these devices, the femoral route is preferred, just because of the stiffness going around. If you're coming jugular and then going into the pulmonary trunk and then into the pulmonary arteries, it's quite difficult, but it's not impossible. So if they have DVT bilaterally,
Exactly.
or a DVT going right up in the IVC, then you have to think about alternative routes, or use a combination of devices to do a DVT thrombectomy and then do a PE thrombectomy. That's a big thing.
In terms of when you put your wires in, do you just put it through the fluoroscopy straight in? Because we tend to access the pulmonary tree by floating a PA first.
Yeah.
So that's what
you use a balloon tip catheter, right?
Yeah, balloon tip catheter.
We have an angled pig tip, and we just lead with that from below.
From below,
Yeah,
all
yeah.
the way up.
Yeah.
Right. Wow.
And we just sort of flick it around. And the pigtail, because we don't want, if we just went in with wires from the right heart or from the right atrium, if it got under chordae, and then we put a 24 French device through chordae, it wouldn't be a good thing.
Yeah.
So you wouldn't get away with it. So you just lead with you can either use a balloon tip catheter. So
we use a balloon.
Cardiologists like using balloon tip.
We use a balloon tip catheter.
But we just use angled pigtails. Yeah. So is that the?
I just brought you to see if we could kind of work out. If you
Oh
can
yeah,
get anything
yeah,
else.
yeah, yeah.
What I might do though is stop because we're going to have a look at the kit, but I don't think that's going to project.
Oh, no,
So I might finish the
yes,
MSc
sure.
meeting and then we
Yes.
can have a look at the
Okay,
kit.
cool. You want to say a word?
So yeah, thanks guys. I'm going to end this because we're going to have a look at the kit, but I don't think that's going to be something we'll be able to see from where the cameras are. So thanks very much for joining, and we'll say goodbye for now.